All right. Well, welcome everyone to our On the Pulse series. I am Chris Fortman, the CEO at the Minneapolis Heart Institute Foundation, and I am so glad that you all made time to join us. Just a little background before we get started on the Minneapolis Heart Institute Foundation. We are a separate independent nonprofit organization, so separate from the Allina Health System, separate from the Minneapolis Heart Institute. This visual kind of gives you an idea that our mission is to improve cardiovascular health through innovative research and education. You can see those in the top circles, and with the result being improving clinical practice with the dissemination of those research findings. So we have been in existence for just over 41 years doing this good work. So what is this work in research and education? We have over 200 active studies touching over 2,000 patients, and half of those studies fall into industry-sponsored clinical trials, allowing medical devices into the clinic to help our patients, and the other half, those studies are physician-initiated research. So the most important pressing questions that our physicians feel need to be answered, we have the resources to support that research. Education is a critical part. We have a paid internship program with over 200 alums here at the foundation. Most of those alumni are currently practicing physicians or in medical school. And during the summer, while those students spend their time with us, they are doing real research with our physician mentors and our research staff mentors, and many end up being authors on manuscripts and presenting at national conferences. Also in education, we provide a CME and community education and publish over 200 peer-reviewed manuscripts annually. So in MHIF current updates, some exciting news. Our very own Dr. Paul Saraja presented a much anticipated late-breaking clinical trial at this year's ACC, the American College of Cardiology Conference. This trial, called Triluminate Pivotal Trial, showed that transcatheter edge-to-edge repair using the TriClip system is safe and effective in patients with symptomatic severe tricuspid regurgitation. The intervention reduced the severity of regurgitation and was also very safe, with a low rate of major adverse events around the time of the procedure. To quote Dr. Paul Saraja, he said, "We feel these results are very meaningful for a highly symptomatic population whose quality of life is impacted by tricuspid regurgitation. And with the excellent benefit to risk profile of the system, we feel that a historically untreated population will now have a treatment option to improve their quality of life." This groundbreaking research was published in the New England Journal of Medicine as a manuscript and was even picked up by news organizations like the New York Times. And as I mentioned earlier, the Minneapolis Heart Institute Foundation is a 501c3 independent nonprofit that relies on philanthropic investments that come from community leaders like you. So I want to take a moment to say we are grateful for all of you who make this work possible. Thank you so much. It is my pleasure to introduce Dr. Edwin Zishiri. Dr. Zishiri is a cardiac electrophysiologist at the Allina Health Minneapolis Heart Institute. Dr. Zishiri received his Bachelor of Medicine, Bachelor of Surgery from the University of Zimbabwe. He completed a research fellowship at the Harvard School of Public Health, and then completed residency and chief residency at the Boston University Medical Center, followed by fellowships in cardiology and cardiac electrophysiology at the Cleveland Clinic. His clinical interests include catheter ablation of cardiac arrhythmias, pacemakers, ICD and BIV device implant, lead extractions, and risk stratification and prevention of sudden cardiac death. He also has additional training in complex arrhythmia ablation. And with that, thank you very much, and I hope you enjoy this session of On the Pulse.
Thank you, Chris, for the really kind introduction. I am delighted to be here to talk to the audience about this important topic of sudden cardiac death and ventricular arrhythmias. I'll start off by quoting Mark Twain, who said, "The fear of death follows from the fear of life." A man who lives fully is prepared to die at any time. However, most of us, despite how fully we live, remain scared of death, and specifically sudden death. So over the next half hour or so, I hope to review the epidemiology of sudden cardiac death, discuss the different causes of sudden cardiac death, discuss the evaluation and management of patients who survive sudden cardiac death, discuss the evaluation of family members of someone who experiences sudden cardiac death, discuss the unique issues of sudden cardiac death in athletes and sudden cardiac death related to exercise. And if we have time at the end, I hope to show some clinical cases and walk the audience through how we make some of the decisions that we make. So sudden cardiac death is a leading cause of death in the United States, claiming more than 350,000 lives each year. Approximately 92% of those people who experience sudden cardiac arrest do not survive, unfortunately. Sudden cardiac death kills more than 1,000 people per day, or one person every 90 seconds, a number that is greater than the deaths each year from breast cancer, lung cancer, stroke, and HIV/AIDS combined. Cardiovascular disease is the leading cause of death in the US, and most deaths from cardiovascular disease are attributable to sudden cardiac arrest, where the heart abruptly and unexpectedly ceases to beat so that no blood can be pumped to the rest of the body. The most common cause of sudden cardiac arrest is a heart rhythm disorder called ventricular fibrillation. And without immediate emergency help, death often ensues within seconds to minutes of an episode of ventricular fibrillation. Sudden cardiac arrest most often occurs in patients with heart disease, especially those who have congestive heart failure or have had a previous myocardial infarction or heart attack. It is estimated that 95% of victims who experience sudden cardiac arrest die before they reach a hospital or any other source of emergency medical help. As many as 75% of people who die from sudden cardiac arrest show some signs of previous heart attack, and 80% of those have signs of coronary artery disease, including chest pain, dyspnea with exertion, etc. This slide highlights the interplay between multiple factors that often lead to the electrical vulnerability that creates sudden cardiac arrest. Oftentimes, it's a complex interplay between risk factors that the patient may have, including advanced age, hypertension, diabetes mellitus, smoking, obesity, genetic factors and family history, patients who have coronary artery disease, congestive heart failure, patients who have genetic predisposition, and the numerous molecular mechanisms that predispose to creating the storm that creates sudden cardiac arrest. And this is a very nice paper for those that may be interested in reviewing. If you divide the causes of sudden cardiac death by gender, you'd note that in men, the vast majority of patients who experience sudden cardiac death can be attributed to coronary artery disease, and a smaller fraction to dilated cardiomyopathy and heart failure, even smaller fraction to valvular heart disease and other genetic abnormalities. Up to 3% of men who experience sudden cardiac death have no identifiable structural or electrical abnormality despite extensive testing. When you look at women, on the other hand, coronary artery disease accounts for a smaller fraction of the causes of sudden cardiac death. It's about a little less than half, 45%. Dilated cardiomyopathy and heart failure are more frequent, as is valvular heart disease. And up to 10% of women who experience sudden cardiac death have no structural or electrical abnormalities that are able to be delineated despite extensive testing. Of course, the genetic abnormalities, including long QT syndrome and other genetic channelopathies, are also represented, but in a small minority of patients. Similarly, if you look at the different causes of sudden cardiac death by age, and I know that this is a slightly busy slide, but it does talk about the different causes. At the top of the slide, it's looking at patients that have genetic arrhythmia syndromes with channelopathies that predispose patients to experiencing sudden cardiac death, as can be expected, usually this tends to happen in the younger population. So if you're talking about catecholaminergic polymorphic VT, which is a form of genetic arrhythmia that can be provoked by exercise or other hyperadrenergic states, the different types of long QT syndrome, which can be sometimes the sudden cardiac arrest can be initiated while sleeping, occasionally by an alarm clock or hearing a loud doorbell or swimming. And there's a different ECG and other characteristics that we can look at. There's also Brugada syndrome. But as you come down that list, you see that, as people get into their late 40s and older, coronary artery disease becomes a more significant contributor to the incidence of sudden cardiac death, as we discussed. There's other rare conditions such as cardiac sarcoidosis, which we see a fair number of patients who have this, hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic ventricular cardiomyopathies, and other conditions as outlined. And I'll come back in a different form and review some of these later on in the talk. So again, it's always challenging to come up with one holistic way to evaluate patients who survive sudden cardiac death. Both the American Heart Association, the American College of Cardiology, the European Society of Cardiology have algorithms that they help to guide clinicians to evaluate someone who has experienced sudden cardiac death. Typically, we need to document if someone did have an arrhythmia, and occasionally people have arrhythmias due to slow heartbeats like heart block or sinus arrest. And if that was the cause of the cardiac arrest, typically those can be treated by a pacemaker if no identifiable reversible cause can be identified. Occasionally, we do find from EMS recordings or other recordings that the patient had a dangerous fast heart rhythm that comes from the bottom chambers of the heart, what's called ventricular tachycardia, ventricular fibrillation. And if no identifiable reversible cause can be identified, then those patients would be candidates for getting an implantable cardioverter defibrillator. And there's various forms of those, and we can discuss that later. Unfortunately, there's also a large number of patients where, despite extensive workup, including exercise testing, tilt table testing, cardiac catheterization, echocardiography, cardiac MRI, and other forms of testing, including electrophysiologic testing, we still have no identifiable causes. And this remains a subject of intense research, which we at the Minneapolis Heart Institute Foundation are also participating in a lot of studies to try to understand. I'm going to switch gears and talk about sudden cardiac death in exercise, related to exercise and amongst athletes. It is well recognized that exercise is one of the most powerful tools for improving health overall. Exercise improves all cardiovascular risk factors, including reduction in weight and blood pressure, increasing the good cholesterol, the HDL cholesterol, decreasing the bad cholesterol, the LDL cholesterol, and increasing sensitivity to hormones such as insulin. Multiple studies have also shown the benefit of exercise, and pooled analyses have shown that even a small amount of exercise provides significant risk reduction compared to a sedentary lifestyle. However, different levels of exercise can produce changes in the heart. It is well described that high-intensity training exercise can lead to an increased cardiac output and enlargement of the heart chambers, and some changes may mimic other pathological conditions, such as hypertrophy, which is an increased thickness of the heart, and occasionally there may be fibrosis, which is scarring within the heart. We have all, unfortunately, especially if we watch any of the competitive sports, have been witness to the situations when an athlete, usually a young person, usually perceived to be the epitome of health, collapses on the field and experiences sudden cardiac arrest. There's been recent episodes that have been recorded on the soccer fields, on the football fields, as also on the basketball courts. And I won't go into the specific of those to respect the individuals that were involved, but I imagine a lot of members of the audience have heard or even seen some of those episodes. The effects of intense physical training on the heart were first recognized by Darling and Henshen, who observed cardiac enlargement in athletes way in the late 1800s. And since then, many subsequent studies have been performed to try to understand the pathophysiology of cardiac remodeling during exercise and its relationship to both health and disease. While there's controversy about the potential connection between intense endurance exercise and the incidence of arrhythmias such as atrial fibrillation, on balance, exercise is clearly beneficial and health promoting for the large majority of individuals. Yet for a small number of individuals, and those who predominantly harbor sometimes undiagnosed cardiac conditions, exercise can sometimes be associated with the risk of sudden cardiac death, what is called the exercise paradox. Sudden cardiac death is the most frequent medical cause of sudden death in athletes, and estimates vary widely based on the population. And the precise incidence of sudden cardiac death among high school athletes, for example, is unknown, but in different studies, it has been estimated to range anywhere from 1 in 23,000 to 1 in 300,000. The key in preventing and screening this population lies in the early diagnosis of individuals who may have underlying cardiac conditions, putting them at increased risk of cardiac arrhythmias and sudden cardiac death. The risk and causes of sudden cardiac death vary based on the athlete population, male, gender, Black race, and basketball participation all place an athlete at a higher than average risk of experiencing sudden cardiac death. The mechanism of increased risk is unclear, although Marfan syndrome and resulting aortic dissection have most commonly occurred in male basketball players. It could only account for a small fraction of deaths in this population. When talking about causes of sudden cardiac death in athletes, it is helpful to consider them by two large age groups: the younger athletes, who are individuals who are younger than 35 years of age, and the older athletes who are older than 35 years of age. The causes of sudden cardiac death in younger athletes is commonly due to inherited cardiac conditions, while in older athletes, it is most often due to atherosclerotic coronary artery disease or blockages in the heart arteries. Studies dating back into the early 90s by Zipes and Wellens, again, stratifying by less than 35 or older than 35, documented that, in the younger than 35 age group, close to half of patients had structural abnormalities such as hypertrophic cardiomyopathy, yet ruptured aorta, coronary anomalies, and others were less prevalent. In those older than 35, greater than 80% of patients who experience sudden cardiac death had coronary artery disease. But, hypertrophic cardiomyopathy, mitral valve prolapse, valvular heart disease, and other conditions were also represented in this population. Again, a different way of looking at sudden cardiac death in athletes. You can divide, though, sudden cardiac death into that which occurs in patients with a structurally normal heart. And most of those patients may have congenital abnormalities in cardiac channels that control the electrical activity of the heart and puts them at risk of abnormal heart rhythms. Examples of these conditions would include Brugada syndrome, the different forms of long QT syndrome, catecholaminergic polymorphic ventricular tachycardia, commotio cordis, which, in early January of this year, I think one of the football players had experienced after he received blunt chest trauma, other channelopathies, occasionally Wolff-Parkinson-White. Of those that have structural abnormalities, hypertrophic cardiomyopathy is represented significantly. There's a lot of patients who may have arrhythmogenic ventricular cardiomyopathy. Sometimes it only affects the right ventricle. A lot of times it affects both the right and the left ventricles. Occasionally it only affects the left ventricle. Patients with dilated hearts and heart muscle weakening, what's called dilated cardiomyopathy. Occasionally you have patients who have myocarditis, which can be related to viral illnesses, and sometimes it's idiopathic. And again, for those that are older than 35 years of age, the commonest culprit would be coronary artery disease. And And it also varies by region. If you go across the pond to Europe and Italy, the most common cause of sudden cardiac death in athletes was arrhythmogenic ventricular dysplasia, which accounted for up to 25% of cases of sudden cardiac death in athletes. Recent data from the National Collegiate Athletic Association suggests that the most common finding at autopsy for sudden cardiac death cases was a structurally normal heart, which was actually present in about 25% of cases, implying that arrhythmias and other electrical abnormalities could be a more significant etiology than previously known. Coronary anomalies are the second most common finding, followed by hypertrophic cardiomyopathy in these younger patients. Arrhythmogenic ventricular cardiomyopathy is a genetic cardiomyopathy with an estimated prevalence of 1 in 50,000 and is characterized by fibrofatty infiltration of the bottom chambers of the heart, as I previously alluded to. Many times this affects the right bottom chamber of the right ventricle, but may involve the left bottom chamber of the left ventricle or both. And the risk of dangerous arrhythmias that come from the bottom chambers of the heart is increased by exercise, especially exercise training with vigorous exercise may accelerate the phenotypic expression of this predominantly genetic abnormality. Pre-participation screening, there's a lot of controversy around this. However, it is extremely important. Though sudden cardiac death is rare in athletes, when it does occur in athletes who are often young and presumably healthy, there's a huge emotional and social impact on the community. And therefore, considerable effort has been made to better understand the causes of sudden cardiac death in athletes and to discover optimal strategies for prevention. Intense athletic activity can trigger sudden cardiac death or disease progression in some susceptible individuals. Pre-screening competitive athletes can improve the detection of cardiac abnormalities and minimize the risk associated with athletic participation. All pre-participation screening programs are aimed at identifying athletes who are at higher risk of sudden cardiac death and should begin with a focused history and physical examination. The addition of a 12-lead electrocardiogram or other additional cardiac testing is a source of considerable debate, and the varying societies that give guidelines are variable in the recommendation about that. Both the American Heart Association and the European Society of Cardiology advocate for pre-participation screening of young athletes on ethical, medical, and legal grounds. However, they differ in that the American Heart Association recommends taking a thorough medical and family history along with a physical examination, whereas the European Society of Cardiology recommends a routine addition of 12-lead electrocardiogram in the initial screening stages. Competitive athletic screening should consist of a targeted personal history for the athlete in question, a family history, and a physical examination. This includes 12 key pre-screening elements, such as a history of elevated blood pressure, knowledge of certain cardiac conditions in family members, and the presence of a heart murmur that are designed to identify or at least raise a suspicion of underlying heart disease that might place the individual athlete at elevated risk. Those athletes with positive findings should be referred for further and more detailed evaluation and testing prior to competing in competitive athletics. It is very important to recognize that the EKG cannot detect all disorders that predispose to sudden cardiac death in athletes. For example, the ECG is normal and therefore unable to identify the majority, greater than 90% of individuals with congenital coronary anomalies. Furthermore, the EKG may be normal in 5 to 10% of patients with significant structural abnormalities such as hypertrophic cardiomyopathy, and in 25 to 30% of patients with genetically associated arrhythmia syndrome, such as long QT syndrome. Similarly, the resting ECG is usually normal in patients with catecholaminergic polymorphic VT, which can be a trigger for sudden cardiac death during exercise and competitive athletics. Therefore, it is highly unlikely that any screening program will be effective at appropriately identifying all athletes at risk for sudden cardiac death. For that reason, the Pre-screening should be a thorough and comprehensive evaluation of the individual patient, taking into account all the available data, including personal and family history, symptoms, physical examination, and ECG or echocardiogram if needed. Unfortunately, even with all these precautions, pre-participation screening is not perfect, and some cases will be missed. Thus, it is crucial to increase the access to automated external defibrillators, as well as training the general public in cardiopulmonary resuscitation at the community level, which means reducing the risk of sudden cardiac death in the general population as well as athletes. As we all know, nowadays, if you walk into any public space, whether it's a mall, an office building, a hospital, etc., there's oftentimes easy access to AEDs, which can be used even by lay people to perform life-saving resuscitation. We now live in a technology-driven world. A lot of people wear wearables, watches, and other things that can monitor heart rhythms. And there's ongoing extensive investigation into quick delivery of CPR using automated technologies such as drones, where a drone would be flown and directed to a sudden cardiac arrest victim, supposing their watch or other wearable device detected this, and there's ongoing investigation and excitement about these technologies. Again, this is another slide looking at an evaluation algorithm, and this one is taken from the European Society of Cardiology guidelines. So if someone survives sudden cardiac death, it's very important to obtain a comprehensive history about the circumstances under which this occurred, any symptoms that might have happened prior, any family history of sudden cardiac arrest, and proceed to identify if there's any structural abnormalities or if this is a non-cardiac event. Occasionally people can get blood clots that go to the lung, pulmonary embolism, bleeding, other things that can cause sudden cardiac arrest. However, if it is cardiac, there's need to proceed to evaluate the exact genetic cause, and which also has implications for the family. An evaluation for the relatives, again, if the index person in the family who experiences sudden cardiac arrest gets a detailed evaluation and a precise diagnosis is established, it becomes very easy to have a discussion with the surviving family members and first-degree relatives about their specific risks. Oftentimes nowadays we do genetic testing, and if we identify a genetic mutation that puts these people at risk, the appropriate family members can be appropriately screened, and based on whether or not they're positive for the mutation, they may be at reduced risk, or if they positive, it may be at elevated risk, and we can discuss the different options, whether they be medical therapies or devices or closer monitoring to try to reduce the surviving relatives' risk of sudden cardiac death in the future. I have a few references here for us to look at, and I'll be happy to share those at the end right here. Otherwise, we will proceed and review a few cases at the end here. So some real world cases, and the audience may be interested in this. I will try to be brief so that we have time to answer questions at the end here. The first case is a 60-year-old female with hypertension, high cholesterol, and heart failure due to a non-ischemic cardiomyopathy, meaning she does not have any coronary artery disease. She also has frequent premature ventricular contractions, which are a frequent number of beats that occur prematurely from the bottom chambers of the heart. She had been on good medical therapy and was referred by a cardiologist to heart rhythm specialists to consider implantation of an ICD. The EKG is shown below, and you can see that there are these normal narrow beats and these wide beats, and every other beat is one of the wide beats, which is the PVC. And on subsequent Holter monitoring, which is longer term heart rhythm monitoring, not just the 10 seconds that we typically see on a 12-lead EKG, this patient had a PVC burden that approached 50%. So the therapeutic options were, should we implant the ICD as requested? Her ejection fraction remains less than 35%. She's been on good medical therapy for 12 months. She has some extra heartbeats from the bottom chambers of the heart, and that may portend a higher risk of arrhythmias in the future. Or do you want to repeat some of your testing, including heart catheterization, echo, MRI, and such? Do you want to start a heart rhythm medication? Or do you want to do something else, such as recommend ablation? After a careful evaluation of this patient, we recommended an ablation procedure because there's a subset of patients where these extra heartbeats can weaken the heart muscle, cause the cardiomyopathy, and increase the risk of sudden cardiac death. I know this is a busy and fairly technical slide, but up here, you see when we come on ablation, those wide beats, this was the last 2 wide beats that the patient had, and subsequently for the rest of their life until now, since I'm still following these patients, they haven't had any more PVCs. This is a map from when we mapped in the electrophysiology laboratory, and this is a cartoon depiction of the right ventricle, right bottom chamber, which is a crescenteric shape, and in the front, part of that right bottom chamber is where this extra heartbeat was coming from. In subsequent follow-up, this lady's heart function has improved to normal. She no longer has symptoms. She has not required an ICD, and she remains a very happy person that we're able to identify that these extra heartbeats that come from the bottom chambers of the heart were the reason why her heart muscle was weak, and through an invasive interventional procedure, we're able to get rid of these. The second case I would like to show is that of a 48-year-old female with sickle cell disease. She had paroxysmal atrial fibrillation. She also had a non-ischemic dilated cardiomyopathy. Her EF had been down to the 10 to 15% in the past. She had a biventricular pacemaker with a defibrillator that had been implanted in the past. She was having very frequent extra heartbeats that come from the bottom chambers of the heart, and actually came into the hospital with shocks from her defibrillator because she was having sustained ventricular tachycardia. The EKG is as shown, and again, this is blown up and a little different than EKGs that people who have seen EKGs may be used to seeing. But again, you see these wide beats over here, which are the extra heartbeats. But unlike the other ones, these ones are much wider. If you look at how wide that QRS is, it's wide. It's got some slurring on the beginning portions of it, what we call the intrinsic deflection. And this may suggest that these extra heartbeats come not from the inside of the heart, but more from the outside surface of the heart, what we call the epicardial surface, or deep within the muscle. And it may be challenging to consider an ablation procedure for this patient. And there's different criteria that can be utilized for that. For this specific patient, we had to do the intricate and complex ablation procedure of going with a specialized ablation catheter, which you see here on the outside of the heart. You see a defibrillator wires right there. And when you're on the outside surface of the heart, there's critical structures that you worry about, including the heart arteries, which are depicted in the angiogram, the gray lines that you see there. And then you have to make sure that you're far away from a branch of the heart arteries. Occasionally, you may also be close to the nerve that supplies the diaphragm, the phrenic nerve, and there's different tests that you do during the procedure to make sure that you are in a safe place after you map where the extra heartbeats are coming from, and you take care of them. And similar to that case, we were on the epicardial surface of the heart, on the outside surface of the heart. We came on ablation, and within, less than a second or so, we were able to terminate that arrhythmia, and that patient has continued to do well. The third case is a 49-year-old man who had previously had heart attack and anterior myocardial infarction. His heart function was mild to moderately impaired, but not to the extent that he would have required a defibrillator. He presented to the emergency room after blacking out. He had been having some beers with his nephew. Apparently, he had 8 beers, and then he collapsed suddenly in the bar. There were first responders in the bar, 2 of whom were RNs and 1 was a firefighter. They performed CPR. And after about 3 minutes, he regained consciousness. He did not require shocks. At the time when we evaluated him, he had a large bruise on his forehead because he had really collapsed and had no control of how he landed. His physical examination was otherwise normal at the time. He had an EKG, which is shown below, and that EKG shows evidence of the previous heart attack in the front part of the heart that we have seen. What shall we do? Shall we send this guy to heart catheterization? Should we tell him that drinking 8 beers in short succession is a bit too much and bad for his health? Should we implant an ICD? Should we do something else? Or should we do all of the above? So for him, because we're highly suspicious that this was an arrhythmic syncope or sudden cardiac death that had self-terminated, we took him to the electrophysiology laboratory and we were able to induce a dangerous fast arrhythmia that comes from the bottom chambers of the heart, from the area of scarring in the front of his heart where he had the previous heart attack. And he subsequently had a defibrillator implanted. So in summary, based on the discussion we had, sudden cardiac death, as we have discussed, and I tried to show with some of the cases, comes in a variety of flavors. Coronary artery disease is a very common underlying cause. Extra heartbeats that come from the bottom chambers of the heart, PVCs, can lead to heart muscle weakening and can at times cause sudden cardiac death. When you have any doubt about your risk of sudden cardiac death, talk to your doctor about testing and possible referral for evaluation. Thank you for participating in this discussion. I'll be happy to take any questions that you may have.
All right. Well, thank you, Dr. Zishiri, for your time and expertise during today's On the Pulse session. Truly a fantastic presentation. And hello, everyone. My name is John Rickert. I'm the virtual event lead here at the Minneapolis Heart Institute Foundation. Just jumping on here to help facilitate the Q&A portion. So the questions that we have prepared today did all come through via registration. So thank you to our registrants who submitted a question, but please also feel free to add additional questions using the Q&A pod, which is located at the bottom of your Zoom screen, as those questions may be discussed in future On the Pulse sessions. So, Dr. Zishiri, the first question comes from an attendee who asks, for those who have survived sudden cardiac arrest, are there any changes in quality of life following the event or increased risk of recurrence?
Okay, that is an excellent question. And if there's anything that we know about sudden cardiac death, is that many times the past predicts the future. So someone who has experienced sudden cardiac death is at very elevated risk of recurrent sudden cardiac death, which is why if you are fortunate to survive sudden cardiac death and after an evaluation, if there's no identifiable reversible factors, most patients would typically get a defibrillator, which would help decrease the risk of sudden cardiac death. So a defibrillator, I talk to my patients, is almost like a little guardian angel. If you have a recurrent dangerous arrhythmia, it can save your life. So you're not at the mercy of your family members or the emergency medical services to save your life. But that said, I mean, it depends on what is your risk of sudden cardiac death. Some factors, suppose you had a heart muscle weakening and you're now on really good medications and you follow up with your doctor regularly and you're taking the medicines and following the changes in your diet and such, it would decrease your risk of future events. Most patients that suffer sudden cardiac arrest, of course, have their quality of life affected by it because they're scared about it happening again. Their family members are equally scared, but there's lots of patients who survive sudden cardiac arrest and continue to live good, healthy lives that can be prolonged by all the medical and device interventions that are available.
Mm-hmm. Yeah, absolutely. And interestingly enough, the next question that was submitted has to do. The question is, how effective is the defibrillator implant?
Right. So defibrillator implants are extremely effective in selected patients. I think there's many cardiologists who are proficient in implanting these patients for the right, implanting these devices for the right patients. So if your evaluation suggests that you need a defibrillator, I think it's a reasonable thing to consider. They are more than 99.9% effective in terminating these dangerous arrhythmias that are experienced in the field. And other than, the discomfort that may be related with the shock or the initial discomfort with the implant, since there's an incision and some pain involved, most patients can lead a pretty good life, and it's a very effective implant if indicated.
Yeah, that's great to hear, and thank you for that. So the next question that an attendee put in the next question that an attendee submitted was, and I know you spoke about this in your presentation, but the question is, how many sudden cardiac deaths could have been avoided with genetic testing?
Right. So genetic testing is always extremely challenging because, as we may have learned from the talk, there's different genetic variants that can affect individuals and put them at risk of sudden cardiac death. And some of the people that experience sudden cardiac death is just a structural abnormality in the heart. They have scarring in the heart from a previous heart attack, or scarring in the heart from previous myocarditis, or scarring in the heart from other unknown non-genetic causes. So the genetic causes tend to fall within a smaller category of those patients who experience sudden cardiac death. Like we had discussed, the younger the patient, the more likely that they may have an underlying genetic abnormality or channelopathy. And through taking the history, there's different genetic tests that we can do now to try to identify what is a specific mutation. And after we have an index case, we can go ahead and screen the family members to figure out if they have that genetic mutation. And if they do, then we can discuss their specific risk of sudden cardiac death and how we can mitigate that. So from a population point of view, it's a little challenging to do just because, if you screened everybody, got a genetic test, positive predictive value would be very, very low. But with targeted, more precise testing, where you have an index case, maybe an EKG that suggests that some person has a genetic abnormality, and then you can more precisely target the family members. I hope that answers the question.
Yeah, definitely. And thank you for the insight. So the next question we have, this attendee writes that they have AFib. And the question is, does that increase the risk of sudden cardiac death?
Not directly. I mean, if you have atrial fibrillation, depending on your risk factors for getting a blood clot in the top chambers related to atrial fibrillation, the most important aspect of treatment of atrial fibrillation is determining what your risk of getting that blood clot is and trying to mitigate that risk, usually with blood thinners, whether it's Coumadin or Eliquis or one of these newer blood thinners. If you're on an appropriate blood thinner, depending on your risk of a stroke, the risk of a major catastrophic event related to atrial fibrillation is low, very low, no higher than average, I would say, for age.
Interesting. Thank you for that insight as well.
Yes.
So the next question has to do with genetics and heredity as well. But the question is, this attendee's husband, who has 79, and her son, both who has 59, both died of sudden cardiac arrest, unfortunately. So what part does heredity play?
Right. So I'm sorry to learn about these unfortunate and catastrophic events in this family, but the age of the person's husband and the son would make it highly likely that the underlying abnormality was probably related to coronary artery disease. There are risk factors that can run in families, high blood pressure, high cholesterol, other things we may not necessarily understand that predispose someone to getting coronary artery disease. So unless if either one of the deceased people had an autopsy or to have a better understanding of what exactly was the cause, just looking at the ages involved, I would not necessarily think this is a primarily genetic arrhythmia syndrome. If anything, I would be more worried that it's coronary artery disease or something like that in the family.
Mm-hmm. So the next question, this attendee writes that they have a pacemaker.
Right.
What signs should you be aware of that informs you that you need to see a doctor?
Right. So most patients or all patients that have pacemakers should follow up closely with their cardiologist that follow those pacemakers. So if you have any symptoms that could be coming from your heart, and this could include shortness of breath, chest pain, decreased exercise endurance, a sensation or awareness of your heart racing or palpitations, I think you should be go ahead and talk to your doctor, make sure that you can get seen. If your pacemaker is beeping or alarming for any reason, sometimes that could indicate that there's an abnormal heart rhythm or some malfunction related to the pacemaker. And it is important to reach out to your pacemaker clinic and your doctor to make sure that you get evaluated for that.
Yeah, absolutely. Thank you very much for that, Dr. Zishiri. So the next question has to do with screening. I think we've covered screening pretty well. So maybe we can jump to the next one, which is, excuse me, sudden cardiac arrest in athletes has been in the news lately, specifically with the soccer player who had collapsed on the field. So is there actually an increase in this happening? And if so, what explains this? Or is it just, a hot button news item, which sort of, increases the attention on this situation?
Right. So again, sudden cardiac death in these highly competitive athletes that we watch on television and streaming services and such is very, very rare. It's in the order of, one in several hundreds, thousands. But of course, when it occurs and we see it on TV, it's a hot button issue that we talk about. And even if the incidence was to increase by a little bit, just because of how rare it is, it's really tough to say that I think it's increasing in any, systemic way. I think we're just more aware of it. And then sometimes these things just tend to happen in short succession, not necessarily because it's more frequent, but it's just happening at that time.
Totally. Makes a lot of sense. So the next question, the question is, why has the COVID-19 pandemic increased the rates of sudden cardiac arrest? Is this true? And if so, why?
Well, the numbers related to COVID and sudden cardiac death, it's always very challenging, right? I mean, there was a period of time, in early 2020 to maybe even a year and a half to 2 years afterwards, when a lot of the public, despite having been vaccinated, despite new therapeutics being available to improve the outcomes of patients who experienced COVID, a lot of patients were very reluctant to seek medical attention. So someone could have symptoms suggestive of a heart attack, but they were so scared that if they went to the emergency room, they would get COVID and maybe that would kill them. So there's a lot of patients who did not seek care during COVID, and they had heart attacks, didn't get the appropriate care related to that. And then subsequently, they might be at an increased risk of sudden cardiac death. So that's one category of patients. There was also a period of time during COVID when it was just more difficult to get access to your doctors in the healthcare system because especially early on in the epidemic, the hospital system was overwhelmed by the number of patients who required intense care for COVID. And it's the whole system, from the EMS services to nursing, to ICU care, to supplies, to physicians, to specialized services and such. So that may have contributed some. But I would say the biggest contributor related to COVID would be the reluctance of some patients to seek care when they should have, and people sat at home and had their myocardial infarctions, which could have been treated with stents and medications and other things, and then they suffer the consequences that are related to that. Also directly related to COVID, some patients do get inflammation of the heart, what's called myocarditis. It's a very, very, very rare complication of COVID infection, and even a rarer complication of the COVID vaccines, especially the mRNA type vaccines. And when you have that myocarditis, in some patients, it can predispose you to getting scarring in the heart and causing dangerous arrhythmias. But that's a very, very small minority of patients related to COVID.
Yeah, fascinating, and certainly a lot of factors there, obviously. So I know that we're coming close to time here, so maybe we just do a couple more. The next question, this attendee asks, what excites you most about the future, and specifically tying in research and care relative to sudden cardiac arrest or sudden cardiac death?
Okay. Well, I think, I've been an electrophysiologist now, dealing with heart rhythm disorders after training for close to 10 years now. And just watching the space of what is available for patients between targeted molecular diagnostics in the appropriate patients. I think now, after the Human Genome Project, 23andMe, all these other things even that are available through without even prescription from your doctor, of getting genetic testing and understanding your genetic risk of certain conditions, including cardiac conditions. That space is evolving. Now we have good, reliable diagnostic tests that can find out if you're at risk of having one of the genetic arrhythmia syndromes very easily. And as we understand more about those genetic syndromes, they may be able to prescribe more effective treatments or develop new treatments. Even in the device space, there's different types of ICDs. The subcutaneous ICD is one of the ICDs that became licensed when I was a fellow, actually. And even the traditional forms of ICDs have completely evolved in how they can treat these arrhythmias, how long the battery lasts, how the patient can interact with the health system and their device, including the use of smartphones instead of, not necessarily always coming to the device clinic to do that. So I think there's a lot of innovation in the heart rhythm space that is going to help patients in preventing sudden cardiac death in the future, understanding the people that are at risk of sudden cardiac death, coming up with new treatments. And I think active research in that area is extremely exciting.
Absolutely. Well, appreciate the insight. And certainly technology, as technology continues to advance, so will patient care. So all good things, certainly. So if people want to find out more about this topic, where can people go to find out more about this work, research that takes place, or, I guess also any specific open MHIF research studies?
Right. So we at Minneapolis Heart Institute Foundation are fortunate that we have a long, track record of participating in groundbreaking research that has brought state-of-the-art cardiovascular technologies and treatments to the patients in the greater Minneapolis area and beyond, or even the surrounding states of patients that come here. So I'm extremely proud and feel privileged to be part of the group here. We have a new heart rhythm innovation and science center where we are participating in research studies. We've always had a genetic arrhythmias clinic where, say, patients who had suffered sudden cardiac arrest can come and be evaluated. Their family members can also be evaluated, and we have a very detailed and thorough process of trying to identify what initiated the sudden cardiac arrest in that patient or their family. Are their family members at risk? We have genetic testing, genetic counselors, and such. So we participate in a lot of research in that space.
Yeah, that's amazing. And I can certainly also put a link into the chat pod should folks want to take a look at that as well. So Dr. Zishiri, thank you so much for your time. Do you have any final words that you'd like to say to our audience?
I just wanted to thank you for the opportunity to participate in this discussion. I think sudden cardiac death is near and dear to my heart. And to be honest, I do a lot of things in the heart rhythm space, and this is one of the tougher things we do because it's sudden. Many times it's unexpected. A lot of times it affects some very young people and such. And we always are trying to see what we could have done or what we can do in the future to decrease the impact of this condition out there.
Absolutely. Well, thank you so much, Dr. Zishiri. That's all the time that we have for today. And thank you to all of our attendees who joined us this afternoon. We do appreciate your participation. Before we sign off, I just wanted to mention that this will be the last session of our spring 2023 On the Pulse series, but we will pick back up again in the fall. If you're curious in checking out our previous recordings, all of our previous recordings from a variety of topics and specialties are available on our website and YouTube channel, and I can add a link to the chat pod to that as well. And with that, thank you to everyone. Thank you, Dr. Zishiri, again. Fantastic presentation, and everyone have a great rest of your day.
All right. Thank you, John.
Thank you. Bye.